So talk me through that. You're doing this lymph node dissection primarily prior to the hysterectomy.
Correct. Yeah.
And you're getting into the retroperitoneal space prior to getting access to the peritoneal space?
Correct. So we inject ICG into the cervix, as you would do for any case. And then we make our way transvaginally into the retroperitoneal space, actually to the obturator area, to the place where your obturator nerve exits the pelvis at the level of the obturator muscle. And then from there, you start your dissection caudally to cranially, down to upwards. And actually, the CO2 does most of the dissection for you. It opens the space up. I think besides the fact that it's less invasive and your patient's flat, another advantage is that you follow the sentinel node as it is distributed naturally, the ICG. You go down to up. Whereas if we come laparoscopically from above, we see a green node and you may get excited and say, oh, I've got the sentinel node, I'm going to take this one out. But you got to be careful not to take the second or the third node because that can be green by the time you come already as well. Whereas in vNOTES, you don't have that risk. You come from the bottom, you automatically, the first green node you see is automatically the sentinel node. So I think that's an advantage that in time with more studies, there will be a good place for vNOTES in that group, I think.
And that's done posteriorly, initially with the access for the node dissection. Is that?
There's two routes of dissection. Initially, we started like a Schauter incision, which is a lateral vaginal fornix incision, and then dissected the paravesical space. It works. It's a bit more difficult to teach that access. So now we're actually moving to an anterior vaginal wall incision, similar to what you do for an anterior repair, and do the dissection from there. And we found that it's easier to teach that access to people who don't have Schauter experience. So it's like you're doing an anterior repair. You just go a little bit more lateral and you jump over the arcus tendineus, and then you get into the right space paravesically.
It just sounds like you guys are almost, as much as you guys have done, it sounds like it's just tip of the iceberg right now for what's possible with vNOTES. It sounds like there's a lot of potential.
I think what we see is we just get different anatomical access now. And the more vNOTES we do, it's a gradual process. It's been over 10 years. I've done over 2,500 cases. So it's not something you do in the beginning, but you learn your anatomy in a different way. And we actually get to spaces that are difficult to reach laparoscopically. We're doing promontory fixations via vNOTES in urogyn as well now. And that presacral space, the dissection there, you're seeing structures that I've never seen before laparoscopically just because we're coming in from a different angle. So there's definitely a lot of room for development in vNOTES still. And I think the most exciting thing is that we just, we see our anatomy transvaginally in a very different way, and we get to reach different places.